طيب, I think we can start now because already it's 1:10. Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wa salam ala Rasulullah. Welcome all of you to my presentation today. My name is Mohammed Bara. I'm working in King Fahd Medical City. So thank you for attendance. Today we'll have like field of exam. I will have the part of eco quiz and eco coding. So we'll show you at the start just the coding sheet, as I know that this eco coding is just brought in the final exam, or in the in the like board exam on final year. However, it's better to be trained from now about this exam, because usually have short like duration to answer every quiz in the exam. And it is also as important because, however, MCQs for promotion in F1 and F2, also that will bring for you like some eco clips, as well as some ECGs, CAF, AB tracing, whatever, and angio during the MCQs. Okay, so it is included in the MCQs. So it's very important also to have just general idea about the common question of eco. So usually for people of F3, you'll have this like sheet. However, it is now very useful for our now quiz. So let's now have like just enjoying our time with these quizzes. I have about like 40 questions. So we don't have time. Each quiz or each question will have just 2 to 3 minutes to answer. So anybody know any one of the answers, just chat in the chat box, okay? And we'll have like 30 seconds to 1 minute, then we'll have the answer and explanation. So usually this coding sheet of eco, as you know, it is well divided. So it will speak for the first part or the first column on your left hand about the LV size. It is enlarged or small. So if you have any enlargement of LV, you have to pick it or small. Then ejection fraction, it is normal, hypodynamic, or moderate reduce or severe reduce. What about diastolic function, if he has any diastolic tracing? Wall thickness, concentric or asymmetrical hypertrophy, wall motion abnormality. So any wall like anterior anterociptal, inferior posterior and apical wall, if you have wall motion abnormality, you have to pick up here, and according to the type of wall motion, like it is hyperkinetic, akinetic, dyskinetic, or aneurysmal or pseudoaneurysmal. If you have any LV masses, like tumor or thrombosis, if you have any complication of infarction, VSD, or papillomaceous rupture, then we'll go to the RV size and function. Then left atrium, if you have enlarged left atrium or any masses inside the left atrium, or then the right atrium, again enlarged, or you have any masses like myxoma or thrombus. Then we'll go to the valves. We'll start by the aortic valve, and the most common, usually, like finding an aortic valve, is the degeneration, calcification, rheumatic, bicuspid, vegetation, prolapse, or abscess. Then the mitral valve is rheumatic, degenerative, cleft. You have flail, you have prolapse, you have any SAM. Then tricuspid valve structure, same, almost same. If you have any vegetation, also there's like a coding under the concerned valve. Then the pulmonic valve. So each of these valves usually have coding. The pulmonic valve usually have very like a few like congenital anomaly or vegetation. Then this is for the anatomy of the valves, 4 valves. Then the function. Do you have like stenosis or regurg for each valve, and what's the grade? If a grade mild, you can pick up. If moderate or severe, this is making your life easy. So it is not important to know this is exactly moderate or severe lesion. Just pick up moderate to severe. If you have prosthetic valve, also you can pick up from here. And then this is what is the type of prosthetic valve here? It is mitral mechanical or bioprosthetic. The same for aortic and tricuspid. And what about the function? Okay, or any complication of this valve? Normally function, or you have high gradient, you have like stuck valve or rocking dehiscent or endocarditis. Then diseases of the proximal aorta and aortic root, like Marfan, dissection, coarctation, aneurysmal dilatation. If you have any cardiomyopathy, especially hypertrophic, obstructive or non-obstructive. If you have apical HOCM, restrictive or dilated cardiomyopathy or non-compaction. Then if you have any of these finding in the echo suggested any systemic disease like amyloidosis, carcinoid, hypereosinophilic syndrome, or pulmonary hypertension. Then the Picardy disease like effusion, thickening, or tamponade. Finally, this is important, congenital heart disease, and usually they will ask about all of these, mainly ASD, all types of ASD, all types of VSD, subaortic membrane, or PDA, coarctation, we said upstairs, tetralogy of Fallot, or coronary fistula, or epistem. So, and if you have also any shunt, left to right or right to left. So now we have about 25 like participants. We'll start, Bismillah, for the first case. Okay, it's not important here to write all the findings, but just if you have 2 to 3 finding, just please write in your books. Okay, and also it's important to know not only the finding, any complication of this finding in this echo. What I know usually in the exam, especially of FF3, they asking you to code 4 answers. However, sometimes you may know just 2 or 3, but you can just write at the end that, for example, you have normal like LV size or normal LV function, normal ejection fraction, especially if it is related to the finding, and also normal RV. So excellent. Let's see the answers. So it's aortic dissection, aortic aneurysm, severe aortic regurg, and dilated LV. So some of you, they know the answer. The most important here, you can see that the aortic root is dilated. So you have to pick up number 1, aneurysmal aorta. Okay, I think nobody wrote this, aneurysmal aorta. Then it is complicated, or yeah, there is somebody wrote dilated aorta, complicated by dissection and complicated by severe aortic regurg, which is here eccentric. Okay. Okay, so if somebody will ask you this is aortic regurg is mild or moderate to severe, this is moderate to severe, likely severe because very eccentric, and this is a complication of aortic dissection, and also is complicated by dilated left ventricle and left ventricle dysfunction. Excellent. Number 2. You know the issue sometimes if you have busy slide like this, especially if you have movie, sometimes some of them will hang, but it's okay. Take your time. It's a bit difficult question, but it is very common in the exam. Okay, so let's see the answers now. Yeah, many of you answer correct, but there is one incorrect answer. So you can see here, this is likely modified apical fourth chamber, and this is focused on the, okay, on the both atria and the mitral and tricuspid valve. So what do we notice here? We notice that there is a defect of the primum septal canal, okay, and there is likely bidirectional shunt. Why? We have red and blue color. Red and blue, that means it's bidirectional from left to right and right to left. And you can see here. Then this is short axis is the same. What do you observe here also? Mitral and tricuspid valve are on the same level. Nice. So when we put Doppler here, CW, we notice that we have mainly right to left and some left to right. So, and in short axis across the mitral valve, we have dilated RV and compressing the LV, and this is like a D-shaped septum suggestive of volume overload because mainly in the history. So, and you have cleft mitral valve. So all of these are suggestive of what? As you said, this is AV canal defect. Okay. Let's now see the answers. So this is AVSD, biduction shunt to cleft anterior mitral leaflet. And this is very common association. If you have AV canal, as I said, usually you don't have any rim at the septal, okay, at the cushion side. If you have just rim, that means this is secundum. So this is primum because you have complete obliteration or absence of any septal rim at the AV cushion. And the mitral and tricuspid valve are on the same level. That means this is common, this is common atrioventricular valve. However, it is not clear here because it is not the same level. And as you said, this is common association to have just cleft mitral leaflet. And you have to comment about if you don't know any other answer, like number 4, we can see that we have dilated right ventricle and RV dysfunction. Nice. How can we know? Is it congenital view or adult view? However, if you are in adult cardiology, they'll bring just adult cardiology. In adult exam, they will bring for you only adult views, no congenital view. However, it is very clear that this is just adult views. Risk of LVOT obstruction, no adult with AVSD. What do you mean no adult with AVSD? It can be picked up sometimes at adulthood. We have many patients with pick up later. Okay, next. Cannot survive with balanced AVSD. Of course, they will come with heart failure. But however, some patient, as you know, they will come late with heart failure, with right side heart failure, cerebral hypertension, as you mentioned, as in this patient. But it will not come like at age 30, 40, maybe 14, 15 years, something like this. Or some of them were just neglected for some reason. Okay, this is, I think, very easy, and this is very common. Some cases are difficult, some are easy because you have to fill the exam. As in the real exam, you have difficult cases, you have easy. But the issue, how can you pick up 4 codes? It's not that we know that maybe you have 2 codes, very easy here. So let's see the chats. Just collapse. Okay. As you see here, we have like significant pericardial effusion, large effusion, and in M mode we have diastolic collapse, and we have dilated IVC. So it's easy that we can answer this is large pericardial effusion with tamponade. And if you want to pick up more, you can just write that LV is normal and RV is normal, something like this. Next. Okay, maybe it's not that a clear case, but what's the hint here? What's the hint? Okay, the hint that you can see that in this view with color, if you don't know what's the problem in 2D, you can have a help by the color, Doppler, or by any other modality like CW, PW, whatever. They may bring for you contrast, mode, whatever. So sometimes, yes, from the first look, it seems this is normal. Normal LV thickness, LV thickness, normal LV size, normal like ejection fraction, all visualized segments are normal. However, by color, we can appreciate very easy that we have like systolic acceleration flow across the LVOT. It's not across the aortic valve. Special aortic valve motion here is normal or opening is normal. And what do you observe here in the CW? What we call this sign? Somebody wrote aortic stenosis type. Oh, yeah, this is dagger shape. This dagger shape. So if you write aortic stenosis, this is not correct. Why? because this is not the typical jet of aortic stenosis. This is called late peaking. Late peaking, okay, gradient here. And the velocity here is about 5. This is 4 meter, 5 meter. That's mean the peak gradient is about 125. This is uncommon in aortic stenosis. However, it may happen. But once you have very large peak gradient or peak velocity, you have to think about LVOT obstruction, okay, more than just degenerative aortic stenosis. Unless if you have very, very severe degeneration of aortic valve, very calcified, not opening, like cement. We saw some of these cases. Yes, the peak gradient may reach more than 100, 120, 140 sometimes. But however, aortic stenosis jet is usually parabolic, is rounded in shape. Okay, yes, some late peaking, but not like this. This is dagger shape. So you have absence of the first part, and just you have dagger shape, and this is called dynamic obstruction. That's mean at late systole, the obstruction start to happen. Not like in aortic stenosis. Aortic stenosis, you have most of the systolic period after finish of the isovolumic contraction till you start with the isovolumic relaxation, just immediately before that. But this is very clear at only the second half of systolic part. So likely, if you don't know what's this is LVOT obstruction. We are sure about this. And you may reach that there is some thickness in the LVOT. So if you want to pick up something, right, this is hypertrophic obstructive cardiomyopathy. This is obstructive, okay? Nice. However, sometimes they may bring for you like ridge, muscular ridge, or subaortic membrane, and it is the coding sheet as well. So you have to notice not every LVOT obstruction means this is HOCM. You have to see the thickness of the LV wall, especially the septum. However, in the exam, they will bring for you very clear cases of HOCM, not like this. This is just very mild LV wall thickness, and sometimes we see this in HOCM. How to differentiate, you mean, between HOCM and subvalvular membrane? Okay, this is very easy. In HOCM, the thickness is usually 40 millimeter or more, while in subvalvular membrane, it is normal thickness. And this is likely just a tunnel shape, usually, and usually very, very close or adjacent to aortic valve. Okay. However, sometimes it's difficult unless if you have full study, and sometimes even we may need MRI or TE. However, by color Doppler and by CW, all are the same. All are the same because both of them may cause LVOT obstruction. Okay, this is good comment. He said intraoptic septum 30 millimeter in HOCM. Okay, anybody can comment about this? This is because very important point. We have to comment about it. Is the intraoptic septum 30 millimeter in HOCM? The answer is no, not always. Yes, this is one of the criteria for just primary ICD. 15 is enough. Yes. So by definition, HOCM, if you have more than 14 millimeter of thickness, okay, and should be asymmetrical. Asymmetrical thickness more than 14 millimeter. This is typical for hypertrophic, okay, or septal hypertrophic obstructive cardiomyopathy. We have other types. We have many other phenotypes, like we have concentric HOCM. In concentric HOCM, even we may have more than 15 millimeter. It may reach 20 or 30. However, 30 is just indication for primary ICD if you have no other indication. This is one of strong indication. But for the thickness, you have to have 14 or more millimeter. Asymmetrical should be to diagnose septal. This is the type of septal hypertrophic cardiomyopathy. It could be obstructive or non-obstructive. Okay, then you have to have absence of hypertensive heart disease. That means the patient is not known to have hypertension, or he was known but he doesn't have this before. And to have more further investigation, you have to do MRI because you have to differentiate between hypertrophic, like hypertensive heart disease, which cause usually concentric hypertrophy, or just hypertrophic cardiomyopathy HOCM. And this can be differentiated by MRI and by genetic study. So remember, yeah, for ICD is 30, for diagnosis more than 14, or some books they said 14 is enough. But you have to have other criteria, not simple like this. Okay, this is very, very important because you'll have many of these questions in the MCQs. Nice. Next question. We said this is Hawker. Next question. This is easy. So till now we have one answer, another answer. This is the related LMS. Okay, there is good answer. He said this is ethereal mass, could be vegetation, could be tumor, mostly myxoma, and we have severe LV dysfunction, ethereal mass, myxoma by ethereal enlargement. Okay, so the most important finding here is what? Mass in the left atrium attached to the septum. Okay, so it could be any tumor, benign or malignant. It could be thrombus, and it could be what? Vegetation. So the most likely cause here is left atrial myxoma. Anybody can write why it is likely myxoma? What's the hint here? Density. It could be, but also it could be thrombus. LA attached. Okay. Intra-atrial septum attached. Yeah. So number one, it is attached to the septum. So for myxoma, usually attached to the septum. Okay. It could be in the right atrium. Yes, we saw some cases of RV. Rarely, of course. But however, if it is in the left or the right, this is usually attached to the septum. And usually attached by what? I will show you here. It's not working, unfortunately. It should be by peduncle. Density, yeah, pedunculated and it is septum. Heterogeneous, yes. What else? There is something here you can see here. By color, what do you observe by color? You can see that the color is infiltrating inside the mass. And this indicates that this is likely myxoma. Because in myxoma, as well as the hyper, like vascular masses, mainly malignant, you may say that the color is infiltrating inside. That means contained inside the tumor or the mass. And this is against thrombus and against what? Vegetation. Okay, so remember, usually left atrium, most commonly, if we bring for you left atrial mass, it could be thrombus, it could be myxoma. So a thrombus usually will be attached mainly to the site of the left atrial appendage or the roof, and it is usually more lineated, okay, while the bulky masses are myxoma, usually pedunculated like here, and it is hypervascular and attached to the septum. Okay, so this is left atrial myxoma. You can comment that's right that the LV was bit dilated with dysfunction RV. However, the most important finding here is the myxoma. Okay, next. Okay, here I need from you just four finding. We have four findings here. Let's see the chat. ASD, tricuspid regurgitated RV, ASD secondum, moderate to severe TR, large RA. Okay, you are right, but we have another finding. Okay, just concentrate. So you have here shunt, that's right. This is left to right. If you write secondum ASD or if you write Baton formula value or are correct, you have likely moderate, at least moderate TR, moderate to severe. We'll have dilated RA. What else? They may bring one common like finding in the exam. It is there. Anybody can notice? Stenosis. I think there is no stenosis here. Tricuspid valve is opening well, and you don't have flow acceleration across tricuspid valve. So there is no CT. Somebody wrote CT, and this is abbreviation of crista terminalis or CT scan. Okay, that's right. This is the Eustachian valve. You can see the Eustachian valve here. It is like just filamental hypermobile structure here. Linear filamental hypermobile structure. Like is attached to the IVC site, is not attached to the septum. Nice. If this structure is attached to the septum and not attached to the roof or the IVC orifice, this is likely what? This is likely Chiari network. Crista terminalis, in this view, will appear just a thickening, fixed thickening, usually at the roof here. It will not usually extend there, and if extend even, it is usually fixed line, is fixed linear structure. But this is uncommon. Commonly, you'll have just like thickening here, like rounded here, rounded thickening here, and this is the crista terminalis. But if it is like very prominent, okay, it will yeah, just extend to the septum like just a linear fixed structure, not filamental like this, not hypermobile. Okay, so you are right. We said this is shunt. And if you write ASD, please, or BFO, you have also on the coding sheet, as I told you, at the end, is it left to right or right to left? If you have bidirectional, you can both code both of them. So this is left to right shunt, okay? Patent foramen oval. And you remember, as you see here, there is no gap likely in the septum. So likely this is just a PFO. If you have big gap, this is ASD, and usually it is secondary. BFO, Eustachian valve, dilated right atrium, or Eustachian valve, dilated right atrium, and TR. I think there is something I have to comment. Somebody wrote apical displacement of tricuspid valve. This is, I think, you cannot comment about apical displacement. That's mean you have a thinking about or suspicion of just a Bishton anomaly. And usually in this case, he should bring all the RV view for you because the main issue, the main pathology is in the right ventricle, as you know. And we can come to that later. But it is just apical displacement because what's the definition of apical displacement here? Yes, it is less than a millimeter. Here it is just a few millimeter here. If more than an 8 millimeter, but should be what? Indexed. That's mean per meter square. More than 8 millimeter, that's mean this is apical displacement, which is not the case here. Okay. Let's go to the next now. Okay, let's see the answers. Okay, good. Many people pick up the diagnosis. So what do you observe here mainly? If we go to the findings, we can see that there is small pericardial effusion and we have large pleural effusion as you're comparing to the just the descending thoracic aorta. This effusion is anterior to that. This is pericardial and this is posterior. So this is pleural effusion, significant. You have significant thickening of the walls of LV. So like this is concentric LVH. And as you said, this is hyperechoic, so sparking of the LV wall. And we have dilated left atrium. Nice. What else is important to diagnose amyloidosis? PE, not tamponade. Yeah, this pericardial effusion, small, not tamponade, that's right. So what's one of the clues to diagnose amyloidosis in any case that you'll have what? GLS. GLS, of course, if he bring for you, that's mean like he's bringing amyloidosis or just hypertensive heart disease or Hawking, whatever. But I mean in this case, or any case, that will have atrial arrhythmia, either atrial fibrillation or other like extra atrial systole, as in this case. What else? As some of you said, there is likely very high E velocity in the mitral inflow Doppler pulse wave. So this is indication of significant diastolic dysfunction, likely it is restrictive cardiomyopathy. So here we have restrictive cardiomyopathy is very clear. Of course, I cannot see the E and A wave clearly, okay, because of the multiple extrasystoly, atrial extrasystoly. It is sinusoidal, but this is also indication that we have likely infiltrative heart disease with this thickness, pleural and pleural pericardial and left atrium dilatation, and sometimes also the thickness of the mitral valve and aortic valve. Likely we are talking about amyloidosis. Nice. Any question here? It is restrictive, yes. Restrictive cardiomyopathy. So you have to pick up LVH, restrictive cardiomyopathy, pericardial effusion, if you have pleural effusion as well, left atrium, and amyloid heart disease. Okay, next. So we have now three answers. Mechanism, severe heart aneurysm, VSR. Okay, so that's right. The answer here, you can see here that we have aneurysmal dilatation of the apex, mainly the septal site or septal segment of the apex. That's right. It is thinned out, even we cannot see here any part of it. And also because there is hinge point. Hinge point is very indication of aneurysmal segment. You know the hinge point, that means this is the discrimination point between the healthy myocardium and the aneurysmal myocardium. This is very typical for true aneurysm. So we have, true aneurysm in the coding sheet, we have pseudo. You have to pick up true aneurysm of the apex. And as you see, there is a gap here, and there is flow mainly in systole. That's right. And why I put this CW? To show that there is now systolic flow. And as you know, this indication, and it is not across the tricuspid valve, it is across, okay, this shunt. So this is shunt from left to right. This is likely ventricular septal rupture post myocardial infarction. So easily we can pick up that this is post myocardial infarction, VSR, ventricular septal rupture. It is true aneurysm of the apex, and we have like severe cystic dysfunction of the LV, and we have dilatation of the left ventricle. Okay. However, VSA with double chamber RV, double chamber RV. Okay. Why you said double chamber RV? It's not easy to diagnose this just from this view. And this is usually very complicated congenital disease. You have to see the short axis and whatever in echo. and even not easy to diagnose just from echo. You have to do sometimes CMR, and they have typical finding on examination, and usually diagnose at childhood. So usually I will not bring for you very complicated like congenital, even the exam. Believe me, in the exam they will bring you very clear and simple cases, okay, especially for adult. In congenital, they will bring for you very clear cases, double chamber RV or double RVOT. It is not of these cases. However, RV function is normal here. However, one of you comment that this is apical akinesia. No, almost always. Aneurysmal apex is dyskinesis, okay? It's not akinetic. So both myocardial function VSD or VSR, thickening and scar of the apex, LV apical aneurysm, and this is left to right shunt. And we have severe LV dysfunction with dilatation. Next. Sorry, uh, I was mute, yes. So I will tell you that somebody wrote bicuspid aortic valve, that's right. And we have coarctation, that's right. But there was one comment that there is severe gradient. Why you said severe gradient? Okay. One comment, mild aortic regurg and aortic stenosis. So, is it severe gradient or mild gradient? You can see here the gradient 22 over 11. And as you know, the normal gradient across aortic valve is 20 over 10. More than this, start to have mild aortic stenosis. So this is mild aortic stenosis. Yes, the opening is nice here, but even sometimes with bicuspid aortic valve, we have some degree of stenosis because the opening still is not normal. Okay, you can see that there is coarctation here. It's very clear that you have some stenosis, and the gradient here is a bit high. Okay, but however, this is not typical for coarctation. But if you bring anything high gradient, this is, by the way, this is suprasternal view, and this is color Doppler, and this is CW, continuous wave. The gradient here, big gradient, is about 2.5 meter. That means is about like 25 to 30 millimeter mercury. Still, it is mildly elevated. It could be because of the aortic stenosis, and it could be because of the coarctation. However, anything usually more than 15 is considered high gradient here, and the differential diagnosis is coarctation or aortic stenosis. In coarctation, we have another typical like a flow. I will show you later in one of the examples. So this is only systolic flow. There is no diastolic. So this is could be coarctation mild, or could be just because of the AS, but here AS is very mild. It will not cause this. So this is coarctation, and this is very common association between bicuspid aortic valve and aortic coarctation. As you know, usually 5% of patients with bicuspid aortic valve, they have coarctation, while at least 50 to 70% of patients of coarctation will have bicuspid aortic valve or any type of aortopathy. So now let's go. What's the grading or degree of aortic regurg? Anybody have clue? You said this is mild AR. Any other suggestion and why? You notice I did not bring any like flow across the aortic valve. This is just 2D. This is the aortic arch. But what's the grade of this AR? What do you think? Sometimes in the exam, will not to bring for you just full picture. Will not to bring for you everything and just to know diagnosis. He want to know in a few questions, what's your thinking process, okay, for the severity of the lesions. He may bring for you just pulse wave, continuous wave, sometimes E velocity, okay, and sometimes maybe bubble study across tricuspid valve or contrast across aortic valve. This is rare, but he may bring for you. So not the clue is only to have just color flow. You have other clue here. Let's see. 7 chat. Severe density, no flow reversal. Okay. However, you can see here that the descending, okay, arm, or you can see this. This is the jet of aortic regurg. This is at the same flow of aortic valve. This is aortic flow jet, and this is my DS, as we said, and this is against to the flow. So this is aortic regurg jet. Here the density is dense. That's right, and even the pressure half time, okay, or the descending time is short. So this is suggestive of severe aortic regurg. However, presence or absence of what we said here in the suprasternal view, we have to put pulse wave, not continuous wave. Pulse wave to see if there is flow reversal. So if you have whole diastolic flow reversal across the aortic arch or descending across the aorta, this may suggest severe AI. However, absence of it doesn't rule out severe AI. Okay, there is some specificity and sensitivity, but it's not that 100%. So you see here it's dense, and there is, as we said, short pressure half time. And as you know, the definition of short half time to suggest severe aortic regurg is less than 250 millimeter mercury. So remember, bicuspid aortic valve is usually complicated by aortic stenosis, aortic regurg, aortopathy, dilated aneurysmal aorta, dissection, and coarctation. All of these may be associated, and it's very rare to bring just bicuspid aortic valve exam. He will bring for you another complication. Okay, so let's go now to the next. I think you saw the answer. This is the issue of some slides is very slow, so you can see the answer. So let's see the answer now. Biostic mitral valve, that's right. So we have biostic mitral valve, that's right. And we have vegetation, excellent. Paravalvular leak. Okay, let's see. So you can appreciate that it's very common to bring for you prosthetic mitral or aortic valve or tricuspid. So how can we differentiate this is metallic, mechanical, I mean, or this is just prosthetic? By many features, mainly in 2D. In bioprosthetic, we don't have metallic shadows, we don't have reverberation artifacts, as we see here. And we have what? Struts of the tissue valve. And struts like columns here and the stents. And we have very thin leaflets like here. So this is like bioprosthetic. The same finding we'll have in aortic valve if you have bioprosthetic. While in metallic valve, you have a lot of shadowing and is difficult to visualize the discs. We have here mass attached to the mitral leaflet, mitral struts, the anterior struts. So this mass is likely vegetation. Okay. What else? We can see here in color. Okay. Struts, yeah, paravalvular leak. So is it paravalvular leak? Dehiscence. طيب, for dehiscence, you have to see very clear what we call rocking motion. Do you have any rocking motion here? Rocking motion, that's mean the valve is just like dancing. We don't have here, to be honest. So don't pick up like serious diagnosis if you are not sure about it. In rocking motion or in dehiscence, definitely we have to have what? Paravalvular leak. So now this is likely 5-chamber focused view again. So I will give you a chance. Do you have any other answer here? This is 5-chamber. Okay. This is the LVOT. This is the mitral valve, tissue valve. You can see the thickening of the leaflets, struts. Okay, so this is like a not paravalvular leak. Why? Because I cannot see anything going to the left atrium. In paravalvular leak or regurg, you have to see, as we say, you have sometimes rocking motion dehiscence, or maybe there is no. Okay, if the valve, the paravalvular leak is small. So you'll have this leak or regurgitant jet is coming backward to the left atrium, and we don't have this here. And this CW across the LVOT. Okay, this CW across the LVOT. So any answer? LVOT, somebody wrote LVOT. LVOT what? What do you mean by LVOT? Aortic valve fibrosis. Do you think this fibrosis is aortic valve? This is just normal. This is normal. We don't have any struts here. However, you have to know that leaflets of any tissue valve are thinner, more thin than the native valve. You can compare here. Do you think these leaflets is native of mitral valve? This is just tissue valve. Okay, this is just leaflet of porcine, or this is just like pericardial leaflet. That's mean this is tissue valve is much thinner than the native mitral valve. While this aortic valve is just native, normal thickness. So the answer here, you can see this is very high gradient. That's right. This is mitral valve, too deep, leading to a bit of suction. No, this is not too deep. This is well sitting, but you can see this mass is causing obstruction. This mass is causing obstruction. This is could be vegetation, could be thrombus, could be remnant tissue of the mitral valve. So we have differential diagnosis here. It could be thrombus, it could be vegetation, it could be remnant. And it was actually a remnant, just tissue of the anterior mitral leaflet, the anterior native mitral leaflet, which was not excised operatively. That's why it now caused some obstruction across the LVOT. And you can see this because the gradient is high, it reach about more than 5 meters per second. So the B gradient is more than 100 millimeter mercury. And it is also clear here in the color that you have flow acceleration. So the answer here is mitral valve regurg, sorry, mitral valve replacement, tissue valve. We don't have regurgitation. And you can mention, if you don't know other answer, that this is well functioning. Because why? I cannot see any regurgitation here. Okay. And even there is no that significant flow acceleration. Okay. So that's mean likely well functioning mitral valve. And we have LVOT obstruction, and we have mass here. You can pick up this is just thrombosis or vegetation. Okay, next. Okay, let's see the answers now. LVH, severe aortic stenosis, mild aortic regurg. Aortic valve stenosis, severe with mild regurg. Normal VC. Okay, so let's see. You said aortic stenosis because of what? Because of high gradient across the aortic valve. This is apical 5-chamber, continuous wave across the aortic valve, and you have very high grade, 74 over 48. Okay. Yeah, yes, that's right. And you said by the autoclicate is very clear in this image. Type. What notice? Do you notice that the aortic valve opening is normal here or no? It is normal, that's right. So what could be the cause? You can see aortic valve opening is clear and there is no flow acceleration across aortic valve. Excellent. It's supravalvular. Somebody said subvalvular with membrane. Somebody else he said supravalvular. So what do you think here? Is it supra or sub, and why? Subaortic membrane type. Now to know, yeah, it is difficult. You know that sometimes it is common to bring for you subvalvular aortic stenosis, especially in case of membrane or ridge or HOCM, okay, septal HOCM. And the grade is high, so you go easy and you write aortic stenosis. It's not right. You have to see the opening of the valve and the thickness. Here, aortic valve leaflets are just mildly thickened, very mildly thickened, but normal opening. Okay, so that means still I have other two different diagnoses. It could be supravalvular, that's mean in the aorta itself, or subvalvular. So do you think there is any abnormality by 2D here in subvalvular region? You can see here, no. Okay, and even by flow, by color flow. By color, there is no any flow acceleration across the LVOT. But you can appreciate that there is some flow acceleration started distally to the aortic valve, as you see here. Okay, and go back and concentrate on 2D. You can see there's some membrane here. Okay, you can see membrane here, and this is likely the cause of this stenosis. So this is supravalvular aortic stenosis. It is not working. Okay. So this is also common in the exam. However, there is no coding for supravalvular aortic stenosis, but you can pick up just this is AS. And do you know any disease may cause? Usually the causes of supravalvular AS is congenital. So do you know other some disease can cause this? Yeah, William, excellent. William disease. It is rare, but this is very nice case. So you have to always do everything together. See the 2D finding, is it correlating with the color, correlating with the gradient, CW, if he giving you planimetry, for example, or no. Because it's not that go ahead and pick up whatever you find from one finding and the other is contradicting. That's mean he's asking and challenging you for other diagnosis. Okay, next case. Okay, let's see the answers now. No answer yet. Okay, go back. It's easy case. Apical Hockham endomyocardial fibrosis. Somebody wrote apical Hockham, the other endomyocardial fibrosis, parachute mitral valve. No, another diagnosis. LA mass, no. Somebody wrote, and he's very shy, flail, and that's right. Yeah, this is flail mitral valve. Why you are going away from this one? You can see here that it's not clear by 2D, okay? Unless if you are concentrating well. But if you are not sure about diagnosis or you don't know what's going on, have help. You have to have a help by other feature, like by color. You can see here, this is two chamber, that there is some MR, some flow here, okay? Not clear. Go here to fourth chamber. What you observe here? Again, very eccentric MR. If you have very eccentric regurg due to any reason, that's mean you are dealing with one valve etiology, likely perforation, prolapse, or flail. And you can see, once I stop here, you can see where is the line of this, okay, closure line or coaptation line of both leaflets. You can see that clearly the posterior metal leaflet is prolapsing and there is total loss of coaptation. And this is called the flail, okay? And this lead to very eccentric mitral regurg, which is anterior directed, okay? And even go back to 2D. You can notice this, that there is some flail here, okay? However, I think you have the privilege, okay, that you can stop the image in the exam and just see what's going on. This is what I think. Just freeze the image and you can just move it, okay, step by step, and to know what's the problem there. Okay, what's the grading of MR here? It is mild or moderate or severe, and why? Let's work it again. Moderate to severe, flail, severe, need more data. Excellent, eccentric jet. Why you need more data? You have already two views here. Apical 2, apical 4. What else more data? Like what, please? Tell me more data. What do you need more? Okay, the answer, if you have flail, that means severe. That's right. So a flail, any flail leaflet for any valve, this automatically will lead to severe regurgitation, okay, by definition. So any flail mean severe, no need to think more, okay? Number two, yeah, it is, you think the size of the jet inside the deuterium is low, but we have very good sign is rarely of, you know it, unless if he's ecophilo. This is called splay sign. What do you mean by splay sign? That's mean in case of severe regurgitation of mitral valve, okay, or tricuspid, the MR jet will not go directly to the left atrium, will go very horizontal, like here, you can see here. And this is called splay sign. This is usually signs of severity. This is well studied, as you see here. However, it is also very eccentric, and this means this is severe mitral regurgitation. Coanda effect. Coanda effect is different. Coanda effect is different. Coanda, that's mean once you have the jet is coming and is hacking the lateral wall or any wall of the atrium, that's mean that the size of the jet will reduce by at least 50%. This is called Coanda effect, okay? And this is usually, yes, in very eccentric regurg. But here, there is no that clear Coanda because it doesn't go to the left atrium wall. It's just very horizontal to the leaflet. If you have very horizontal jet and like the width of it is large, okay, and very horizontal to the leaflets, this indication of severe regurgitation, and this is what we call splay sign. So Quant effect, this is yes, this is one of the phenomenon in severe eccentric MR. That's mean you have severe MR, eccentric is hugging the wall. That's why the power of the jet will be reduced by 50%. That's mean if you have like some size or jet area of regurgitation, you have to duplicate, okay, multiply by 2 to know the real jet area. Okay, we have two phenomena very good to know in MR and significant MR. One called, as you said, Coanda, and the other is momentum. Momentum, once you have severe hypertension, the MR jet will be overestimated. And once you have low blood pressure, the MR jet will be underestimated. And this is applied for functional mitral regurgitation, not applied to like primary MR, like in this case. Okay, next. Let's see. torrential TR, hepatic reversal. Good. What else? Somebody said consecutive pericarditis, severe TR, severe TR. Okay, that's correct. This is severe tricuspid regurgitation. Why you said severe? Because of dilated IVC, but still dilated IVC could be because of pulmonary hypertension. As you see, the right atrium here is severely dilated. The left, and the right ventricle is severely dilated. The septum is pushed toward the LV. That's mean we have pressure and volume overload. So like you are dealing with severe pulmonary hypertension. But what is the hint here for severe TR? Is it the jet-like area here? Is it like color? No. The hint that in hepatic vein we have systolic reversal, time with ECG, and you see this is immediately after the QRS. So this is in systole. And if you have cystic reversal of hepatic vein, this is indication of severe tricuspid regurg. If you have diastolic reversal, this indication of severe pulmonary hypertension or significant pulmonary hypertension, at least moderate. And very common to have both of them, systolic and diastolic reversal. So that's mean you have combination of severe tricuspid regurg and significant pulmonary hypertension, which is very common association, and mainly because of the pulmonary hypertension, which is complicated by severe TR. As you know, the hepatic vein, normally the flow is, okay, it is below the baseline. So anything here, flow is normal. Upstairs, it is flow reversal. And sometimes he may bring for you just live color Doppler across the IVC and hepatic vein to show that there is also, normally we have all the flow is systole and diastole from the hepatic vein toward the IVC, then to the orifice of the right atrium. So all the flow should be in blue color because it's down. But if you have red, that's indication that you have flow reversal. So you have to time with ECG, systolic or diastolic, to know the diagnosis. So if you want to comment, we said severe tricuspid regurg. As you see here, the color is not that important. Size of the jet inside the right atrium is not important. And this is likely because of what? Because of high pressure inside the right atrium. So this will underestimate the size of the TR jet. And this may happen also in case of if you have severe left atrium like hypertension, okay, or diastolic dysfunction, in case mainly of severe mitral stenosis, this will underestimate the size, okay, and severity of the mitral regurgitation. And the other hand that is severe, that you have very wide vena contracta. So remember, size of any regurgit inside the chamber is not that important. We have many other features more important. One of them is the vena contracta. The other is you have any flow reversal for anything. I mean, I'm talking about generally about regurgitation. And this is applied in all valves. Only there is one exception in aortic regurg. We may see that the size of the aortic regurg jet inside LVOT only, not inside the left ventricle. Good. So this is the case. TR severe, RV dilatation, as we said, RV dysfunction, and dilated right atrium. Nice. Next, please. Let's see the answers. Dilated cardiomyopathy. Okay. Tethered mitral valve. LA dilated severe dysfunction. So somebody said this is non-compaction. LV non-compaction. Why you said non-compaction? Please, can you write? It is very clear that we have dilated left atrium. You can call this dilated left ventricle. Okay, the RV you said this is normal, and there is significant cystic dysfunction of left ventricle. So ejection fraction is less than 30. However, in the code system, coding sheet, you have ejection fraction, as we said, more than 50, between 30 and 50, this is moderate dysfunction, or less than 30%, this is severe dysfunction. So why you said non-compaction? Okay, so the correct answer is this is LV non-compaction. So so anybody can write why this non-compaction? Deep crypt. Okay, so number one, you have usually in non-compaction, you have dilated cardiomyopathy. So you have dilated LV and you have LV dysfunction. Okay, because usually this patient will be discovered late. They will have dilatation before they get symptoms. Okay, so usually they are discovered at late stage. Number two, you can see that there is spontaneous contrast here, and this indication of low stroke volume and low cardiac output. Let's see the answer. Color reach the eclipse. Yeah, excellent. So some of you pick up some finding. Number two, three, better to describe this finding as these are trabeculations, heavy trabeculation. Okay, so this is the most important. Heavy trabeculation in most of the LV segments, and usually should be in the apex, start in the apex, then go to lateral and other walls, as you see here. And once you put color, you can see that the color is okay integrated inside what we call this recesses. Okay, or somebody he mentioned crypts, but the better name is just this is recesses. Okay, and this is in Arabic mean نتوءات. هذه النتوءات you can see that the color is okay integrated inside, reaching inside, and cause opacification. Okay, and this is will not happen in other disease. That's mean this is just heavy, non-compacted endocardium. Nice. You can see here also in this view, two chamber. The curve is reaching here and even here. And sometimes he may bring for you one complication of non-compaction, which is just LV thrombus is common association. Okay. So, and there is somebody he mentioned that there is some problem in the mitral valve, tethered mitral valve. Usually if you just have this focused view on LV and color, even I don't focus on mitral valve at all, that's mean I'm not asking you about mitral valve. You can see mainly I'm asking about you about LV, and I have focused view over the apex here with color. And also it's common that he'll bring for you contrast. So contrast also will opacify inside the recesses. However, there are many definitions. Yeah, you said need contrast or MRI to assess the ratio. That's right. This is the criteria which I mentioned now. There are definite criteria. However, in the echo quiz, nobody will ask you about criteria. In a quiz, just bring like typical feature of echo. To confirm, you need cardiac MRI and contrast. As I said, you will have the same finding of color, but more clear that the contrast will invade all the recesses. Excellent. So LV non-compaction, severe LV dysfunction, dated LV, and dated left atrium. Okay, next. Okay, let's see the answers. TAVI, LVH, Batusa septum. Any other answer? Calcified aortic valve, LVH. No. Let's see. Mechanical mitral valve, VSD. There is a lot of discrepancy in answers. Mechanical mitral and aortic valve, mechanical mitral valve and aortic, mechanical. Okay, so likely this is the answer. You know, this is mechanical mitral valve, very clear. As I said, you have a lot of mechanical shadows, so you have not to miss mechanical aortic valve. Definitely in any echo exam or any cardiology board exam, okay, even in the F1 and F2, he will bring for you mechanical valve, either mitral or aortic with some scenario. So you have to have at least 20 questions with mechanical valve. So here you can see that we have very small struts, not like tissue valve. We have mechanical shadow, okay? This is called metallic shadow, or what we call reverberation artifacts. These shadows, we can see this shadow is coming and going with opening of the disc. And you can see some metallic discs are opening and closing. And this indicates this valve function is normal. Okay. Here, is it mechanical? Okay. I don't have shadow, and this is common nowadays to see this. This is TAVI. You can see the stars of TAVI and the net of TAVI is like net shape, okay, or net shadow. And you can see that there is no flow acceleration across this valve. That means this is well functioning. Normal flow acceleration, no regurgitation here. Somebody said paradoxical septal motion. That's right, because of post-operative. Okay. You may have some also wall mobility and posterior wall, but this is not the question. Now, is it enough answer that mechanical valve, TAVI, normal function? There is LVH. Normal function of both of these valves or only one? Normally function. Okay, so the mechanical mitral valve normally function. Why? Because the grade is up to 8. Is 8. 8 is still considered normal in mechanical mitral valve. You remember that in our native valve, normal grade is up to 3. More than 3, you have to start some stenosis. 5, up to 5 is mild. Up to 10 is moderate. More than 10 severe. This if you don't have any pitfalls, but it's very common to have pitfalls, over or underestimation of a gradient in native valve. While in mechanical or tissue mitral valve, that's mean mitral valve replacement, the accepted gradient is up to 5 to 6. I'm talking about mean gradient. The acceptable is 5 to 6 millimeter mercury of mean gradient. More than this, you may start to consider this could be just high gradient. However, they said up to 8, it is still considered as normal in most of the cases, especially if this is the same as post-operative. But if it's raised compared to then post-op, this is that mean some stenosis or high gradient. And even some valves up to 10 is considered as normal gradient. However, as I said, always we have to compare to the post-op gradient. So this is considered still as normal. You see the pressure, this is AFib case, pressure time likely in most of these cases or deceleration. Velocity is normal. And here the gradient across the TAVI still normal because mean 13. And generally we can accept the same like any tissue valve across the aortic valve. Up to 20 is normal, and the peak like a gradient 36. Okay. So this is normally functioning mitral valve replacement, mechanical and TAVI. In TAVI, you have to pick up bioprosthetic aortic valve in the coding system. Okay. So in case of TAVI, just click on bioprosthetic aortic valve. And if you have like mitral clip, this is considered as repair. If you have tricuspid clip, consider as repair as well. Okay, because both of them are percutaneous repair. Next case. Okay, we have to go quickly. Dysfunction are related are no. I want the main. Excellent. McConnell sign. Very nice. So this is McConnell sign. Why? You have dilated RV, that's right. You have dilated RA, that's right. You have some tricuspid gauge is mild. What else? This is hepatic vein. You can see there is diastolic reversal. Time with ECG is diastole. So diastolic reversal. That means I'm talking about significant pulmonary hypertension. Okay, so this is massive pulmonary embolism. Why? Because you can see that dilated RV, the basal and the lateral wall is severely hypokinetic, while the apex is hyperkinetic, and this is typical for RV strain, mainly acute RV strain, and most likely diagnosed here with these findings is massive pulmonary embolism, and this is called McConnell sign. Nice. And there is no McConnell sign in the coding, but this is massive PE, one of the diagnoses, RV dilatation, mild RV dysfunction, and mild TR. Next. Let's see now the chat. This is, I think, is easy. Do we code pulmonary hypertension in the previous case? Yes, yes, of course. So as you see here, this is some pericardial effusion here and also pericardial thickening. That's right. What's interesting about septum here? What do you call this motion of the interventricular septum? And you see dilated IVC. This is, yes, nice. This is bounce septum. Bounce septum is typical for constrictive pericarditis. And this is because of interventricular dependence, variation, respiratory variation between inspiration and expiration. In the pressure of RV, that's why the septal motion will be changed and will go to which chamber have low pressure in diastole. So the septal bounce, and this is mitral inflow. You can see that I'm putting here the spirometer. So please notice if you have an spirometer down, especially if you have mitral inflow pulse wave or tricuspid inflow pulse wave or hepatic vein, that's mean this is likely we are talking about one of two conditions, either restrictive cardiomyopathy or constrictive pericarditis. Okay, this is very, very good and very helpful, and many times we are missing it in the exam. You can see, just follow with me. This is mitral inflow pulse wave, and this is hepatic vein pulse wave. This is tissue Doppler across the medial mitral annulus. You can see also there is spirometer, and this is the tissue Doppler, okay, velocity across the lateral mitral annulus, and there is also a spirometer. So all of these views, four views, all are Doppler pulse wave, and here tissue Doppler. We have the spirometer. So we have one of two conditions definitely. No need to waste your time. This is could be constrictive pericarditis or restrictive cardiomyopathy. And the IVC is dilated. However, it may happen in both of them, but this is more commonly in constrictive pericarditis. Here, any presence of pericardial thickening or any presence of pericardial effusion is suggestive of, or effusion or whatever, suggestive of restrictive, constrictive pericarditis, and this is typical bouncing septum. Okay, so what do you observe here now? In mitral flow, we have respiratory variation, and the significance of respiratory variation in mitral inflow is if more than 30%. Okay, in some books they say 25%. In tricuspid valve, at least 50%. At least 50%. So we can see here that there is, yeah, the difference between the highest or peak of mitral flow and the lowest one, more than like 40 or even 50%. So this is suggestive of significant respiratory variation across the mitral inflow and indirectly suggestive of ventricular interdependence. Here in hepatic vein, what do you observe? You observe that there is also variation during respiration between the normal water flow across the hepatic vein. So you see this curve, when you go up, that means this is inspiration. go down, this is expiration. So there is expiratory what here? Expiratory influence, okay, during or exaggeration during the uh, expiration, and this is suggestive of constrictive pericarditis. The opposite, if it is more influence or more exaggerated during the inspiration, this is suggestive of restrictive cardiomyopathy. Let's go here to the annulus velocity. We have typical finding. As you know that we have like calcium, okay, or section around the heart. The pericardium is thick or calcified, and this is likely attached, this calcium attached to the lateral wall and all the walls of the LV and RV, and this will cause restriction of motion and descent motion of the lateral annulus. That's why the velocity could be normal or low, but as compensatory mechanism during diastole, you will have E velocity of the medial mitral annulus is higher than the lateral. Normally, the lateral should be higher, and you see here the lateral is 8 while the medial is 9. And this is called what we name this phenomenon. This is very important to know. Annulus reversus. That's right. Annulus reversus. That means there is reversal in the ratio. Medial here is higher, and normally should be lower. And this is suggestive that we have restriction around the lateral annulus, and this is constrictive pericarditis. So this is very common question in the exam. As we see here, pericardial effusion small and thickening. It's very important, or I mean very common to bring for you calcification around the pericardium or thickening, like in this case, and sometimes effusion, because we have what we call acute effusive constrictive pericarditis. That means you have acute effusion, it is causing constrictive physiology, okay, and usually it is benign cause if you treat the pericardial effusion very well. Okay, next. Yeah, this is very easy case. This is piece of cake. But what type of cake? I don't know. Large ASD, TR, right side V shape. Any other suggestion? Okay, you know, till now you have many answers are correct and very easy. We see that the right atrium is huge, severe dilated. The right ventricle is severe dilated. Okay, comparing to the left atrium is almost double size. And you know, any enlargement of RV more than the LV, we are talking at least about moderate RV dilatation. So this severe RV dilatation, there is some RV dysfunction, mild likely. As you see, the lateral wall is not contracting well. Why the tricuspid annulus is contracting well? So TAPSE here is normal likely, but this is RV dysfunction because the lateral and the apex are hypokinetic. As you see, the septal wall here is pushed toward LV in both systole and diastole, and this is suggestive of volume overload and pressure overload of the right side. We have TR here, as you see here in this view, and we have some pulmonary hypertension because tricuspid regurg velocity is a bit high. So like you are dealing with mild to moderate pulmonary hypertension. In short axis, okay, you can see very clearly that the RV is severely dilated and there is D-shaped septum in both systole and diastole, but more in systole. Okay. So let's see the answer now. Pulmonary hypertension, D-shaped, cerebral hypertension, that's right. But till now, I need the final diagnosis. Why there is RV dilatation, right side dilatation, and dysfunction? Bubble study importance. Yeah, that's right. It's important. What bubble study showed you? Squashing RV. Squashing RV. Concentrate on bubble, please, and tell me what's your diagnosis. Or can you write what's the finding of bubble first? What's the finding? Iteration, that's right. Anomalous spontaneous, excellent. Sinus venosus. So just see here. This is typical of sinus venosus. From the first beat, you can see bubble occupying both sides of the heart, right and left. It is not shunt from right to left later, not within 3 cycles. This is from the first cycle. You see, just once you see the bubbles, it involves both atria then ventricle, and this indicates you have a common shunt, common channel. Okay, you can see here in the color there is some flow here at the base of this is focus view across the septum of the atria. This is left atrium and this is right atrium. There is some flow here, acceleration flow, and this indicates there is shunt at the base of the septum. And this is likely from the SVC directly toward the left atrium. So this is sinus venosus. And by definition, as we know, in case of PFO, you'll have usually the shunt within 3 to 5 cycles. Okay, more than 5 cycles, like you are talking about, extracardiac shunt or intrapulmonary shunt. More than 10 cycles, this is normal. But here, what you find that there is heavy and massive opacification of bubble from the first bubble. This will never happen with PFO. PFO will have a few bubble coming within 3 to 5 cycles. You can see few bubble or sometimes gush of bubble, but small. Here there is totally opacification by bubble. That's mean this is very huge shunt at the level of superior vena cava. It's opening in one channel to both right and left shunt, and this is usually complicated by right side dilatation. Okay, and this is commonly diagnosed at adulthood when the patient start to have like just symptoms of heart failure and severe dilated RV. So remember, if you have any dilated right side of the heart, you have by default to do bubble, and even if negative, please go and do transphageal echo. T is welcome for any dilated right side of the heart if there is no explanation, if it is not secondary to the left side heart failure or valve disease, or not secondary to lung disease. And commonly we saw patient with dilatation of right side of the heart, and they don't have any shunt bicolor and they don't have bubble. Why? Because there is equalization of pressure in the side inside left atrium and right atrium, and very big secundum ASD. That's why we don't have color between them. So yeah, it is intracardiac shunt. Yeah, this is intracardiac, of course. This is a big intracardiac. This is called sinus venosus atrial septal defect. Okay. And there is pulmonary hypertension, as we said. Next. This is should be quick answer. Okay, nice. This is a Bishten, very clear, as you see here. This is the apical fourth chamber. You can see that there is heavy trabeculated RV, and there is atrialization of the right ventricle. And here you can see that there is apical displacement. Okay, let me just stop it. Yeah, just see what is the insertion of mitral valve leaflet, the medial or the anterior leaflet and medial annulus, and what is the insertion of tricuspid valve, especially the septal annulus. You can see big difference, big distance, and this is called apical displacement of tricuspid valve. We have a giant right atrium, or what we call ventricularization of the right atrium, atrialization of the right ventricle, heavy trabeculation. And the importance of this view, parasternal axis, that we can see tricuspid valve, thickened tricuspid valve. They said once you see the tricuspid valve in parasternal long axis view, start to think, and dilated RV here, start to think about epistem. Okay, you can start to think about epistem anomaly or epistem anomaly from parasternal long axis. You will have usually visualized tricuspid as you see here, and you'll have dilated right ventricle. Okay, any question in this case? Functional pulmonary atresia. Risk for W, yeah. That's for WBW. You have a lot of comorbidity usually in this case. And you have TR as you see here. Okay, Ibishtan. Next, we have to become quick now because we have many cases more. If you can give me the two major findings here, that's enough for me. Two major findings. Calcified mitral valve to valve mitral valve repair. Excellent. So we have mitral valve repair here. It is not calcified. What else? Tricuspid valve repair. That's right. Post leaflet thickens. Type. So you can see here there is like a lanyard shadows. Okay. It is hyperechoic. It could be calcified annulus. Could be MAC. And there is coding for MAC. But is it MAC or this is repair? We have to differentiate. Usually in MAC, you will have the calcification going towards the posterior leaflet more, while in tricuspid valve and mitral valve repair, the annulus is toward the left atrium side more. And sometimes you may also see the other side of the mitral valve repair or the ring on the anterior mitral annulus space. And also usually have some restriction movement of both leaflets, anterior and posterior. This is part of the repair, like here. However, both leaflets here are normal, by the way. It is not rheumatic, not calcified, okay? While in MAC, usually will have calcification of the leaflets and all the mitral apparatus as well. What else? The other hand, that if you can see in this view for chamber, that also there is a ring in the tricuspid valve. By the way, calcification of tricuspid valve annulus and pulmonary valve annulus is very, very rare, not like mitral and aortic. So calcification and degeneration of the left side valves are common, while on the right side valves is very uncommon, unless if the patient has very long-standing end-stage disease or metastatic calcification, and we don't see this commonly. So you have here linear thickening at both annulus, mitral, and tricuspid. And the gradient is acceptable still, 6 mean gradient here across the mitral valve. And even the gradient here or the velocity is acceptable across tricuspid. You have LV dilatation, RV dilatation dysfunction, both atria dilated as well. So mitral valve repair, tricuspid valve repair, and well functioning. Okay, next. So I need 4 answers here, please. Otherwise, don't write. Because this is like just train for the exam. How can you just call the answers? 4 answers. Let's see. This is one answer. Severity of rotation, hepatic flow versus severity of the... You know, endocarditis, I think, is not in the coding sheet because endocarditis at the end, it is just summation of clinical, pathological, and radiographic and echo examination. Severe MR, oh my God. Severity R, vegetation, dated RA, dated IVC. So I need 4 answers from the coding. You know, you said this is vegetation of tricuspid valve. What's this view? This view is RV inflow. So we can see the right atrium and the right ventricle. So we can see clearly that the right atrium is huge, dilated. We have vegetation of both leaflets here of tricuspid valve. Okay, what else? Anterior and septal leaflet. What else? You have severe TR, very clear here. Okay, this is laminar flow, not turbulence because of very huge gap. What else? Very important by 2D finding. Nobody mentioned. Why we have severe TR? Catheter, there is no catheter, sorry. Tricuspid mass. Yeah, that's right. We said vegetation likely. However, what do you think the mass can cause severe TR like this torrential TR? Is only vegetation. No other mass will cause severe or torrential regurgitation for any valve unless it is acute endocarditis. Excellent. This is flail or valve destruction. You have to pick up. This is not simple just vegetation and that's all. This is a flail tricuspid valve. Both leaflets are flail, okay, destructed. That's why you have torrential and central tricuspid regurg. So once you have vegetation, you have to write if you have another another complication. You may have abscess, perforation of the leaflets, paravalvular leak. You will have like pseudoaneurysm or aneurysm. All of these, fistula, all of these are complication may happen along with vegetation, and they may bring this to you. So please take care about this. Next, this is short axis across the aortic valve level. Please, I need like full answer, also four answers. Okay, good. So you said there is pulmonary stenosis. It's clear that you have thickening here at the pulmonary valve. That's right. Okay. And you have flow acceleration. You have regurgitation. Very short duration regurg, but it's fulfilling all or it's filling all the RVOT. Okay. And this indication of severity. This regurg is filling all the RVOT. طيب, here it is, what's the degree? You have to write pulmonary stenosis mild, moderate, or severe because in the coding is not enough to write stenosis or regurg. What's the grading of stenosis and regurg in this case? And why? So I'll answer you. You can see the grade here, the peak is just written here 4 to 3. It is less than 4. So in pulmonary stenosis, the normal gradient in pulmonary valve is peak. I'm talking about peak gradient is 16. And severe is more than 64. So between 16 and 64, mild to moderate stenosis. And here it is 40 plus, and that's mean this is moderate. So more than 36 is moderate. Less than 64 still is moderate. Okay. What about the regurg? Is it severe or moderate and mild? Moderate PS, severe PR. Yeah. Why severe PR? As I said, in color flow, you have very wide vena contracta, and the jet is filling most of RVOT. And you can see here that this is triangular shape of the pulmonary gurge jet. This is CW across the pulmonary valve. So this is the jet of pulmonary gauge. It is dense and triangular. That means there is very steep deceleration time and very short pressure half time. And this indication of significant and really severe pulmonary gauge. So any pulmonary gauge, like pressure half time, 100 meter or 100 millisecond or less, considered as severe pulmonary gauge. Okay, so now you are telling me severe, mild PS, severe PR, but this is still deficient answer. Always, please, this is advice. If you have any valve disease, you have to comment about the morphology in the exam and the like function. So now what I notice, always you are going to the function and you are forgetting what's the etiology. So now this is mild PS and severe PR. What is the etiology here? What is the morphology or 2D finding? Noonan. Okay, yeah, Noonan can cause both aortic stenosis and also what? Pulmonary stenosis. But in aortic stenosis, usually it's subvalvular. No, but what do you notice here? and the Burming valve in 2D, it is heavily calcified. So like you are talking about congenital dysplastic. So most of the time, the pulmonary valve disease, most of the time, it is part of the just congenital abnormally pulmonary valve or dysplastic pulmonic valve. Next, severe aortic regurg. Okay, again, it's severe, but why? Believe me, in the exam, if you called severe aortic regurg without the etiology, that's mean your answer is not that adequate. Yes, it's the diastolic flow, but why, I mean, why? That's mean what's the etiology? Why you have severe AI? Of course, you can see that the aortic gauge is occupying most. This is, by the way, apical free chamber or apical long axis. You can see that the AR jet is occupying most of the LVOT, and this is sign of severity. Plus, the vena contracta is large. And if you go to the color Doppler, the velocity is not that high, so there is no aortic stenosis, okay? Because gradient is 19 over 9. But you will have also likely short pressure half time or deceleration time, and this indication of severity. And this is likely, I don't know what is the location, but likely in case of AR, when he put pulse wave, that's mean this is across the descending thoracic aorta or even abdominal aorta. And you can see that we have diastolic flow reversal, whole diastolic flow reversal. And this is suggestive of severe aortic regurg. Now the question, what is the etiology? You can notice that like this is also flail aortic valve, okay? You can see both leaflets. Where is the leaflet? You can see this one and this one. There's very big gap among of them. It's bit difficult. However, they may also bring flail aortic valve for you in the exam. Okay, next. LVOT obstruction, esophenic LV, no. Apical hypokinesis with LVOT obstruction, no. You are near. There is some obstruction, but where is the obstruction? Okay, listen, I will stop this here. Sometimes somebody should stop for you to know where is the problem. Okay, can you see this? This view here on the right? What do you have here in the apex by 2D and what do you have by color? Subvalvular aortic membrane MAC مايد هذا. Yeah. This is should be common in the exam. Apical Hockham, excellent. This is apical Hockham, spade shape. You can see that there is spade shape of the apex, especially during like diastole. Okay, there is thickness of the apex, but what's more interesting and more clear or clue, you can see during systole that you have flow acceleration across only the apex. Okay, and now you see the hints. What make you confused that yeah you have here high velocity and obstruction, okay, during systole. That's mean likely you have high velocity. It is bit like late peaking. That's mean dynamic obstruction. This is what you call Duggar shape again. But the hint here, and very important, please notice, this is not CW. I'm not putting CW here, and this is not across the LVOT. This is apical, and this is not across LVOT. This is across what? Only here, the apex. This is pulse wave. The sample volume here at the apex. This is pulse wave. This is not CW. So I'm now not taking the gradient across the LV or LV mid cavity or mitral aortic valve, just across the apex. And you see in the apex that I have bigger shape or late peaking gradient. It is high velocity. Okay. And this is typical for apical HOCM. So please, you have to notice this always. Clear. Okay. Somebody here said clear. Thank you. Nice. It's common that if you have any LV apical hypertrophy to have differential diagnosis, mainly apical HOCM, or could be thrombus, or could be what? Hyperesophilic syndrome. And sometimes contrast is very helpful and very common to bring in the exam. If you have contrast, is just have like enhancement by contrast on the apex, this is likely what? This is likely apical HOCM. If there is no enhancement at all and is not contracting after you are injecting contrast without, and there is no enhancement, no contraction, this is likely apical thrombus. Okay, and in apical hyperesophilic syndrome or cardiac or myocardial hyperesophilia, you will have a thrombus with normal contractility. You will have a thrombus in the apex with normal contractility and other findings as well. Okay. Next. Okay, I will make just your life easy. I will give you a hint here. So my question is in the apex. What do you have in the apex here? Here. What do you call this point? This point. This is short axis across the apex. What's this? Let's see. Takotsubo. No. Takotsubo will have dilatation or ballooning. Typically in the exam, you have many types, of course. In the exam, will bring for you ballooning of the apex and midwall as well. But here, yeah. By the way, there is one, yeah, I remember now. One of the previous question was the pulmonary stenosis. There was no BDA. Somebody wrote BDA. There was very, very small short, not important. This is called hinge point. If you have hinge point like this, and the apex is likely dyskinetic, like here, you can see in two chamber. Okay, this is likely true aneurysm. Okay, even you can see here because of wide base across the like inferior segment of the apex in short axis. So this is true aneurysm. And you have LV dilatation and cystic dysfunction. Sorry, I will go back. Chat aneurysm with false tendon, diverticulum. There is some pouch, that's right. Okay. This is here, short axis across the pulmonic valve. Same pulmonic valve. This is short axis across tricuspid valve. This is like RV inflow, this tricuspid. Okay. And this is with color. This is apical fourth chamber. And this is CW across the pulmonic valve. And this is hepatic vein, pulse wave. Let's see here. Okay. Yeah. So what do you have here? You can see that we have severe. You can write some findings in the diagnosis. Severe dilatation of the right atrium, severe dilatation of the right ventricle, RV dysfunction. All septi are shift toward the left side. This indicate very high pressure and volume overload. You will have like what? Loss of coaptation. It's widely open TR, as you see here. Okay. And what else you have? This is very important. We have likely also tricuspid valve stenosis because we have calcified and restricted opening of tricuspid valve. So once you have TR and TS, you have to think about one diagnosis. Again, here I have calcified pulmonic valve leaflets. You can see calcified, some restricted opening is not normal. Okay, because pulmonic valve leaflets usually are very thin and they have significant pulmonary valve regurgitation. Nice. So once I have all of these, the CW across pulmonary valve indicate that I have severe pulmonary gauge here, dense jet and triangular and very short pressure half time likely or steep descent, and they have some pulmonary valve stenosis. And here in the hepatic vein pulse wave, I have systolic flow reversal. That's mean this indication of severe tricuspid gauge. So now I have severe TR, severe TS, or sorry, significant, maybe significant TS. Or even if I don't have TS, I have heavily calcified and restricted opening of tricuspid valve. So the diagnosis is clear here, as everybody mentioned. This is carcinoid, carcinoid heart disease. So in carcinoid mainly, he'll bring for you tricuspid regurg and tricuspid stenosis or calcified leaflet, and pulmonary gauge and pulmonary valve also stenosis or pulmonary valve like calcification and degeneration. Okay. Now let's see this. Yeah, this is easy. Please go ahead. Give me one diagnosis only here. BDA, excellent. This is BDA. As you see in short axis, we have some continuous flow acceleration. This color is red. That means there is flow coming from here to here, from this part to part. And this is usually, this is short axis. So this is the pulmonary valve, aortic valve. Here we have the pulmonary artery. So what will make some car go continuously from here to here? And this is will also be shown in the continuous wave across this flow. You can see continuous diastole, systole, diastole, systole, continuous flow, no flow down, and it's continuous. So this is usually of the PDA. And here on the right side, more clear. You can see the input between the aorta, okay, and the pulmonary artery. So, however, if you have generally, if you have any continuous flow, usually, in one direction, this is could be PDA, or in case of shunt. In shunt, especially if you have like ASD, usually the flow at early stage is unidirectional from left to right. Okay. And if became like significant pulmonary hypertension, you have bidirectional shunt. And in case of Eisenmenger, it is purely right to left, and this is very late stage. Okay, good. Here, also one answer, please, or two. Give me two findings mainly. LV dysfunction, free wall rupture, posterior wall, rupture, posterior wall. Okay, is it now ruptured? This is maybe previously happened. That's right, but now, what's your diagnosis? It's rupture, yeah, there's some effusion here. But what do you call this now? Yeah, excellent. This is pseudoaneurysm of the inferior wall. This is like a complication happen after like a free wall rupture, but this is called contained rupture, please. Don't tell this is free wall rupture. Free wall rupture, that's mean the patient likely will die if you have not sent him to emergency surgery. So this is likely sealed, okay? Free wall rupture, and this pericardial effusion could be the consequence of this. And this is pseudoaneurysm of the inferior wall. You can see inferior wall is totally akinetic or dyskinetic, and we have this pouch. So pseudoaneurysm characterized by narrow neck, like here, it is not wide neck like true aneurysm, and usually happen most of the time on other walls other than the apex. Most of the apex aneurysm usually is true aneurysm, and most of the aneurysm in other walls are pseudoaneurysm. However, it may be the reverse, the opposite. So location is not that the most important, but other criteria like the neck and the like layers of this aneurysm. You can see here there is loss of the myocardium and endocardium. Just we have pericardium here. Okay. So this is pseudoaneurysm. We have some pericardial effusion, and likely, as you said, we have LV cystic dysfunction. Likely, this is complication of the previous contained free wall rupture. Okay. Give me one answer, please, here. Let me see. Everybody say TOF, Taj of Farouk, Taj of Farouk. No, no, no. It's more simple than this. VSD membranous. It is, yeah, it is VSD, but not membranous. It is very, very near from membranous. Okay, but what do you think the location? You can see the location. You see the gap here. You see the color flow here. And in short axis, you can see the flow. It is left to right. This is from like LVOT to the right, okay, through the RVOT. This is the pulmonic valve. However, now I'm not concerning about the pulmonic valve because I did not put any CW here. So this is not question. You can see that they put the continuous wave across this jet, and it is just upward flow. That's mean it's from here to here with very high velocity, 127. And this is likely the grade between the LV and the RV. So the RV here is very normal in pressure. Okay. So this is VSD supracrystal. Excellent. This is supracrystal. Usually perimembranous, the location in short axis at 12 or 11. While if it is like here, very, very adjacent or very close to pulmonic valve, you see pulmonic valve? This is the pulmonic valve. This is not the pulmonic valve. This is just because tilting of what? Of the probe. So this is like the normal pulmonary artery, but you can see here the leaflet. I will show. This is these are the leaflet of pulmonic. These are the pulmonic valve. Okay, and you can see the flow here. So don't care about this. It may happen normally. So location, if the location of the VSD is 12 or 11 o'clock, this is membranous. And this should be at the level of aortic valve, okay? And usually this is the LVOT. But you can see the aortic valve in short axis. Not at the level of like mid LV. Mid LV, that means this is muscular VSD. But if the location at 1 o'clock here, very adjacent to pulmonic valve, at the base of pulmonic valve, this is supracrystal, okay, vertical septal defect, like here. Here it's not that membranous like here, what we see usually. No overriding aorta. لا والله للأسف ما في. No, no. Overriding aorta is like this. Okay, next. I have just a few cases. If better to finish, then we can go and pray. Okay. You can just describe the findings and you may reach diagnosis by this. MAC. Okay, what else? That's right. You have severe MAC here. You have severe aortic calcification and likely stenosis. What else? We have calcified concentric LVH. Yes. You have small pericardial effusion. And you have severe concentric LVH. And you can see that we have atrial fibrillation here, irregular pulse. And we don't have P wave. You have dilated Atria, dilated RV, severe LVH, small pericardial effusion, and the E velocity is high, 120. The E prime is very low, so we have very high LVEDP or E over E prime ratio, 26. So all of this is suggestive, as you said, of amyloidous heart disease. And yes, you can code both restrictive cardiomyopathy and amyloid. Both of them can be coded because, amyloidosis is one of the causes of restrictive cardiomyopathy. Okay, this is very common that you'll find with amyloidosis, as I said, severe aortic valve degeneration and calcification, severe mitral valve degeneration and pericardial effusion, and severe LVH with sparking here, as you said. Okay, this is suprasternal view. I think I give you one example before in this exam, but this is very typical now flow. So what's this? What do you call this? This is correctation, that's right. But why we said correctation? Number one, here you can see in suprasternal there is narrowing and there is continuous flow in systole and diastole, and this is very suggestive of what correctation. And in the continuous wave across this correctation, you will have rat tail sign. Okay, there are many names, but the best name is to tell this is continuous systole-diastolic flow. This is similar to sawtooth, or this is what we call diastolic runoff. That means still you have diastolic flow, because normally, we have only systolic flow in the aorta, but we have continuous diastole after systole, and this is called diastolic runoff, and this is suggestive of coarctation, and also the velocity is very high, more than 60. And as I said, this is commonly associated with bicuspid aortic valve, as you see here, and there is mild aortic regurg and dilated LV. And the cause of dilatation of LV here is the severe coarctation. So coarctation, one of the cause of pressure overload, same like aortic stenosis. It may cause dilatation and even concentric LVH. Okay. I think I brought similar example. It's mechanical mitral valve, that's right. Mechanical mitral valve. So, yeah. If you said mechanical mitral valve, in this case, I will not accept because, as your colleague said, gradient is very high. It is 16, 19. That's mean you have stenosis. That's right. So you have stenosis here, mechanical mitral valve. I don't have a thrombus, but I cannot see the motion of the disc or opening. I have flow acceleration here significant. This is not flow acceleration of a normal valve. Very like dense flow acceleration, very turbulence flow here. Okay. And very high flow. Mean grade here is 16, 19. That means this is atrial fibrillation. And this is indication of significant high grade or mechanical mitral valve stenosis. However, also we have TAVI as you see here, but this is not our question here because I did not bring for you gradient across that. This is very common that you bring for you mechanical or tissue valve of any valve and with high gradient, and this indicates stenosis. But if you have very high gradient with a thrombus or mass, you have to pick up high gradient and stuck valve, okay? If you have a suspicion of thrombus. Okay, let's see the answers here. Still. Let's see the answer. LV aneurysm, severe dysfunction and restrictive. Okay, till now all of this are correct, but there is some major abnormality. So as you see here, there is cystic dysfunction is important, dilatation. Okay, dilated left atrium, mild mitral regurgitation, RV is normal. You can see that E, E over A ratio in diastolic, like flow or mitral inflow, more than 2. And the velocity is here 80. The E prime is very low, less than 3 or 4. And this is indication of restrictive cardiomyopathy or just a restrictive like pattern of diastolic dysfunction. But what else here? Yeah, excellent. There is a thrombus. There is large thrombus. And there is also dyskinesia of the wall. It is not aneurysmal, and we don't have hinge point, and this is just thinned out wall. You can see here, thinned out wall. Okay, if you pick up aneurysm, it's okay, acceptable, because dilatation. So dyskinesia or aneurysm, and there is big thrombus. I think from the first look, we'll miss that because sometimes the examiner may just get attention to us and away from the main finding by putting color here, CW here, and tissue here. Okay, this is very important. Okay, next. So let's see the answers. Severe MR, Casmodronic, yes. No. What's the main etiology here? What's the main pathology? Even severe MR, I will not accept that. Yes, there is degeneration. There is no any artificial valve here. All of these are native valve. Okay. Yes, you may think this is just there is some tissue valve or burstick, but you see anterior metal leaflet in this view is very clear. There is anterior metal leaflet. Okay. Even here. So now we are talking about just there is big vegetation, masses calcified, attached to the posterior metal leaflet and the annulus. And also, if you notice, there is some cavitation here. So this is abscess. Okay, it was confirmed to be abscess of the posterior metal leaflet. Nice. And this is complicated by what? There is MR, that's right, but there is also what here? There is MR originating from the base of the leaflet, and this indicates this is perforation of the leaflet. So we have two MR jet. One is central, and one because of perforation. So consider a severe MR, and this is all our vegetation, and there is abscess. By the way, there is one coding of abscess in the coding system sheet. Nice. Fistula, but where is the fistula? Fistula will not be mentioned if you have direction between two chamber adjacent. I mean, there is now like uh, if you have like cannulation between the left atrium and left ventricle, it is in the normal flow, this is okay. If it is in the opposite, this is called just perforation. Okay. Fistula, if you have a flow between two chamber, which normally you don't have any flow between them. Like if you have between the aorta and the left atrium, or if you have between the right ventricle here and the left atrium, or between the right atrium and the left ventricle. You don't have any flow at all normally. But if you have flow normally and you have after that anything, we don't call this fistula, we call this is just perforation or this is leak, however. Okay. Usually in case of like pseudoaneurysm of the interfiber fibrosis, which happen here, it may fistulate, but usually between LVOT and the left atrium, okay, or the aorta and the left atrium as well. Okay. So vegetation of mitral valve, perforated leaflet, posterior leaflet, and abscess as well with severe MR, two jets with perforation. Okay, this is easy. Please, we need a quick answer. 2 or 3 findings. Looks the picture is just hanging, but it's okay. It's slow. This is pulse wave. This is pulse wave. And this is the left atrium. Hockey stick, mitral stenosis, rheumatic heart disease, rheumatic heart, mitral valve dilated, LV, rheumatic heart disease, MSLV. You know, you'll get 50% of the answer, but why you are just restricting yourself to one answer? That's right. This is hockey stick. There is doming during the astral antimatter leaflet, thickening at the tips, and we have also restricted posterior dilated left atrium. All of these suggestive of rheumatic heart disease, rheumatic mitral valve. Graded here is very high, mean is 11, and this is consistent with severe mitral stenosis. Excellent. What else? Pericardial effusion. Okay. So now 50%. What is the other abnormality in this valve? Yeah, this valve. Let's see this man. MR, excellent. So there is mitral regurgitation, and likely severe. Why? Severe MR, excellent. Severe MR, because you see the jet here. Why you are just seeing here up and you didn't see the down under the baseline? So this is likely. This is MR jet, and this is dense, and you can see here. Sometimes, please, you can see that this left atrium is severely dilated, and we have eccentric jet. It is very eccentric and could be also swirling. Okay. And by pulse wave across the pulmonic vein here, you have some systolic reversal. So this is severe mitral regurgitation. And the cause of this is rheumatic heart, rheumatic mitral valve itself, which can cause now causing some prolapse. Okay, this is rheumatic prolapse as well, or what we call pseudo prolapse. Because of the severely tethered posterior leaflet, this will causing just malcoaptation and pseudo prolapse of the anterior mitral leaflet. Okay, so please take all together. Take all together. Sometimes you are going outside the exam and you are happy. You think that you answer the main component, but you don't see that there is another thing you did not answer that time. Okay, here we have two main pathology. Please answer them, please. Okay, let's see now the answers. How come, Sam? How come? Okay, so you can see here that there is flow acceleration across the LVOT. That's nice. And what else? You have maybe Sam. Usually in Sam, he'll bring for you in mode. Okay. However, this is like there's some code at Sam. There is some, to be honest, you can see here that there is ridge here. There is muscular ridge in the LVOT. And this is the cause of the LVOT obstruction. What else? What do you observe in the aortic valve itself? Aortic valve is thickened, restricted opening, calcified. It's not normal opening, that's right. And there is also aortic regage, which is significant. Aortic regage, which is significant, occupying most of the LVOT. And in continuous wave across the 5-chamber, across aortic valve, you have severe AS here, jet, and you have AR jet. And this AS is likely very high velocity. And this is suggestive again of, you can see the jet here, it is not late peaking. It is suggestive of valvular AS because it is parabolic or rounded in shape. So, and when you put pulse wave across the LVOT, you have Dagger shape or late peaking. So what do you think again? Can you give me another diagnosis? Likely, yeah, there is subvalvular stenosis, but what else you have? We have here combination of subvalvular aortic stenosis and valvular aortic stenosis as well. We have aortic stenosis at the level of the valve, and we have here subvalvular membrane or ridge. Okay, you can see this is the membrane or ridge. This is tunnel shape. So like this is a ridge. Membrane, you have more membrane, more thin. However, if you call this is membrane, that's excellent. In the exam, sometimes he may give you just a still image like this to show you where is the level of the stenosis. And as you see here, the like flow acceleration started at the level in the subvalve. So now my diagnosis again, this is subvalvular aortic stenosis because of aortic subaortic membrane or ridge, and you have also aortic regurg. You have aortic valve stenosis as well. So you have the two jet here, jet of AS by CW valve, and you have jet of the subvalvular aortic stenosis by pulse wave. So can you give me diagnosis now? Give me diagnosis if you have both combination, AS and subvalvular AS. What could be the diagnosis here, or what could be the disease which can cause this, both of them? Schwann complex. Yeah, the spelling is Shone. That's right, Schwann complex. Nice. Okay. Likely I will choose maybe the rest of the cases. Sorry. Because I have many slides, but because our time is very limited, I will choose like two cases and finish. So what's your diagnosis here, please? This is very easy. This is the aortic valve. You can see the morphology or 2D picture of aortic valve. This is color. This is suprasternal view. This is the aortic arch and ascending aorta. Pressure half time here is very low. So the case is easily what? And this is diastolic, holodiastolic reversal. Severe AR, severe I. Why severe AI? I have told you many times you have to give me the etiology. You can see here, what's the problem here? You have vegetation and you have flail, okay? Vegetation and flail, excellent. Okay. This patient is post cardiac surgery. So this is very nice case. So can you tell me now what's your diagnosis? Or finding then diagnosis. This is parasternal long axis. This is parasternal short axis at the level of aortic valve. And this is same with color. Same view with color. This is apical, okay, 5 chamber. And this is apical 4 chamber. Let's see the answer now. TGA? No, not TGA. Garbuli defect? All of this finding and you went to Garbuli defect. بعدين this is Garbudi ما هو Garbudi by G not J. Churbudi. Excellent. Who said this? Repaired to Traj of Pharaoh. Can you tell me why? It is repaired here at the level of the just overriding aorta. You see this direction of aorta and aortic valve is toward both LVOT and the RVOT. Okay, even the plane of the leaflet is toward the RVOT more than LVOT. So this is likely overriding aorta. But it was corrected by repair here. They put patch. So likely will not have any flow here. Number two, you have trabeculated, heavy trabeculated right ventricle. Number three, this is what you have here, subvalvular pulmonary valve stenosis. You'll have very heavy trabeculation here. And you'll have also flow acceleration. That's mean and regurg. That's mean like I have pulmonary stenosis. And when you put this CW across the pulmonary valve, you have very high gradient. It is 100 millimeter mercury of peak gradient across pulmonary valve. And this is indication of severe pulmonary stenosis. So now, what's the cause of severe pulmonary stenosis here is subvalvular here, as you see here. Heavy trabeculation obstructing the RVOT. So RVOT obstruction here. So the fourth component is the VSD. I did not bring here the view because it was repaired. However, you may tell sometimes it's trilogy of Farut. If you don't have VSD, just mention this is tetralogy of Fallot. If you have VSD, this is tetralogy. But this case is, as you see here, is just repaired. Especially they repaired here. However, sometimes subvalvular bronchial stenosis may happen later after surgery. And there's TR as well here, as you see. Okay, this is quickly a case of pulmonary valve stenosis. You can see this is short axis across the pulmonary valve. It is calcified, restricted opening, and you can see here that there is severe flow acceleration and very eccentric. And the gradient here peak is 65. As I said, any pulmonary valve peak gradient 64 millimeter mercury or more, this is indication of severe pulmonary valve stenosis, and you can call this is like a dysplastic or congenital abnormal. This is the most likely cause of PS, and you have here also RV and RA dilatation with dysfunction, and the septal motion consistent with a pressure overload of the RV. Okay, and here is a case, as you see, myxomatous mitral valve, severe dilated left atrium. So anybody can give me full answer in this case. I give you half of the answer. Here on the right, this is pulse wave across the pulmonary vein, and it showed very clear systolic reversal, and this is suggestive of severe MR. However, don't care about this shadow or line shadow. This is because the patient has like chest deformity and spine deformity, severe kyphoscoliosis. So sometimes you'll see this shadow is pushing this is just part of the spine, pushing the left atrium. So as I said, there is, okay, what we said here, primum ASD. Somebody said Marfan. This is excellent answer. Why? Why you said Marfan? Because we have myxomatous mitral valve. You can see here in apical four chamber, you have flail, okay, prolapsing and flail. Posterior mitral leaflet, that's why you have severe MR, swelling, okay, very huge MR jet, anterior directed, as you see here. What else? Yeah, because you have prolapse or MAHADA, and you have dilated aortic root. So once you have dilated aortic root or aneurysmal root or dissection, whatever, and you have prolapse or flail, and myxomatous mitral valve, like you are dealing with Marfan disease, or anything can cause hyperelasticity syndrome. And this patient is actually has Ehlers-Danlos syndrome. Okay. Thank you very much. I finished my cases, in spite a few cases I did not give you because of our restriction of time. Do you have any question? Okay. Thank you so much. Mitral inflow different question about mitral inflow different of tamponade and constriction. Okay. You see, mitral and tricuspid inflow are not specific, not specific, not sensitive. So you have difference between respiration, cycle, and inspiration and expiration in both mitral and the tricuspid inflow when you are putting the pulse wave in many conditions. One of them is the constriction. The other is tamponade. The other is if you have just like bilateral effusion. If you have significant chronic lung disease like COPD. If the patient is on ventilator. So it is totally non-specific. Okay. But it is slightly higher sensitive. That's mean if you have this symptom with other findings of constriction, you start to have to think about constriction. If you have these findings with other findings in echo suggestive of tamponade, this is also very suggestive of like high diastolic filling pressures as secondary to tamponade. Okay. And this is what we call echo evidence of tamponade, especially if you have like significant effusion or acute effusion. So at the end, I cannot differentiate. Both of them are the same numbers. In mitral valve, you have to have difference, 25% or more. In tricuspid valve, in the old days, they said 40, nowadays 50, some people 60%. However, 50% is enough to mention. طيب, suppose you don't have this, okay, like respiratory variation of both mitral and tricuspid flow, still you cannot rule out constrictive pericarditis, and still you cannot rule out tamponade. But if you have this is just extra points to your diagnosis, may suggest you diagnose more. However, the most common is not this disease. Most common you see in ICU. Patient on ventilator, patient has bilateral perfusion, massive PE or COPD and other chronic lung disease or emphysema. Thank you so much. جزاكم الله خير وبالتوفيق دائما. الله يبارك فيكم ويعطيكم العافية.